Good afternoon. I appreciate the opportunity to speak at the Seattle Science Foundation. I'm going to be talking about posterior cervical fusion using a minimal access technique with stabilization of the facets with a cage screw construct. I am a board member and stockholder of Providence Medical Technology, which is what I will be talking about. Most people consider the ACDF an extremely successful operation, and I agree, it is, in healthy patients where you're doing 1 or 2 levels. But what we know is that when patients have multi-levels or they have risk factors for non-unions, they don't heal. Posterior cervical fusion is the go-to operation if you have a non-union, and the fusion rates with a posterior cervical revision are like 100%, but the clinical results are less encouraging. And many people attribute that to the myofascial injury, the soft tissue exposure required to do a posterior fusion. And Providence has a tissue-sparing technique with facet cages that's FDA approved for the treatment of a pseudoarthrosis and to back up a 1 to 3 level anterior cervical fusion. The instruments are just, there's really nothing to open. They're all prepackaged and sterile. You really need a scalpel and a small neuro mallet in order to do the procedure. The first indication that we received from the FDA is treatment of a pseudoarthrosis. As I said, risk factors for a non-union are multi-level. They typically occur at the base of the fusion. Other risk factors, diabetes, old age, osteoporosis. And it's a nice technique for treating a pseudoarthrosis without a large posterior open surgery. The second indication is an adjunct to an anterior cervical fusion. And it can be up to 1 to 3 levels. And that was a recent FDA approval based on a 200-patient prospective randomized trial. There's many approaches to the anterior spine. I mean, everyone's familiar with the standard anterior approach. Most people use it for degenerative disc disease. It has some downsides, but it's an avascular approach. Patients are in and out of the hospital. Posterior approaches involve stripping the muscles off the spine, retracting the soft tissue. They're associated with more blood loss, longer operative times. Medicare data indicates the average patient's in the hospital for 4.5 days after a posterior cervical fusion. Risk factors for a non-union have been very well described. They include multi-level fusion, nicotine use, diabetes, osteoporosis, and probably the biggest factor was a 3-level ACDF. And so when we approached the FDA, they felt that was probably the biggest problem that they saw from their perspective in terms of number of revisions done. When people have a 3-level ACDF, the revision rate's been reported up to 50% and higher. The technique can be done a variety of ways. It can be done mini opens, tissue sparing, almost completely fluoroscopically guided. You can make the incision as small as 1 centimeter. I typically use 1.5 inches or more. I don't find the incision of the skin keeps the patient in the hospital. It splits the muscles down to the spine. You're not stripping all the muscles off the spine, and in that sense, that's the main source of morbidity. And it's complementary to any anterior cervical fusion. The device is pretty straightforward. We have 1 fluoro today. It's preferred to use 2. It just makes it faster, but it's certainly possible to do it with 1 fluoro. We have a facet access tool, which enters into the facet and acts as a post. And once that's in, you can't rotate it. It's fixed. We used a rotatory decorticator over the post. The decorticator is removed, a guide tube is inserted, rasps and decorticators are used to remove the cartilage within the joint itself. The cage is inserted and it has 2 supplemental screws, one going to the facet above and one going to the facet below. This is just an example of a patient, multi-level. The non-union, you can see, is the top of the construct. The patient was revised with facet cages posteriorly, and you can see that the pseudoarthrosis resolves. I mean, it is a very high fusion rate for repair of a pseudoarthrosis. This is an example of an incision. It can be done bigger, it can be done smaller. It's really up to the surgeon. And that the main indications would be a pseudoarthrosis or a 2 or 3 level fusion in which the patient has some risk factors for non-union. We just completed, it was to be a 300-patient prospective randomized trial, but the FDA stopped the study at about 200 patients. We had 200 patients. They all had a CT scan and flexion extension at 1 year. All the films were reviewed by an independent core lab, the same lab, Medical Metrics, that did the MOBI-C trial. And we used CAT scans with coronal reconstructions and flexion extension films. And that was the basis for determining whether they were fused or not. And the fusion rate for a 3-level ACDF alone, and now there's no cages, that's a plate and bone graft, was 19% at 1 year. And with a circumferential approach, it was 66. Now, some people will say, well, a CT scan is, maybe that's too high of a standard. If we looked at flexion extension films, over 2 millimeters of movement at 1 or more level was seen on a 3-level ACDF 50% of the time. 20% of the patients in the ACDF arm ended up having crossed over in a period of 9 to 14 months post-op. So 20% of the patients who had an ACDF subsequently had a revision at about 1 year. So the FDA recently cleared it for use of multi-level ACDF, actually up to 3, 1, 2, and 3 levels for the treatment of multiple level disease.
That sounds like it was a radiographic study. Were there any clinical outcomes associated with it at all?
Yeah. So,
was there a difference?
Yeah. So first of all, 20% crossed over from just anterior alone to circumferential. The NDI, DAS scores, it wasn't really powered for that. It was powered for fusion. So there wasn't a difference, but that excludes the 20% who crossed over who were doing very poorly.
So sometimes, it depends on the surgeon when they like to offer revision surgery. Sometimes it's because of clinical symptoms. Sometimes it's just radiographic where, surgeon perceives that there's going to be a problem and says, right, we might as well just back it up. So was that actually evaluated, or are they just looking at the crossover?
No. Any patient who crossed over had to be reviewed by a second surgeon to make sure that they agreed with it, and they had to have some radiographic evidence of a non-union. Typically, it was at the lowest level, but sometimes the upper level as well.
Another question I had, has this been used, I understand we're on an on-label discussion, but just has anyone used it as a standalone posterior device at all, or is there an indication for that?
Well, it's not FDA approved for adjacent segment disease. In my own experience, talking outside the company, if someone has a collapsed arthritic level, it's not mobile above a fusion. Adjacent level arthritic, it works well. If someone has a hypermobile level above a fusion and without an anterior graft, I don't think it's a good idea.
Okay. And I'm sure you'll show it to us in the lab, but often, the ACDF is a 6.7 or 5.6, sometimes 7.1. And so 2 questions. 7.1 also, because the facet's a little bit different, 7.1, is it a candidate there? And question 2 is, what if you can't visualize the anatomy laterally very well? I mean, is that a complete contraindication, or is it surgeon judgment?
Well, you get better over time, number one, in terms of visualization. So a 7.1 would not be a first case. I've done 7.1, and it is possible to do it. I mean, obviously, if you can't see, it's not safe, and something else should be done. It's not, the FDA clearance for is 3 to 7, but the anatomy is not that much different. It can be done. I have done it, and I've had good results.
I mean, it sounds like great, a great option. I mean, any other questions? Okay.
Well, I'll hit the lab. We're
I'm
just
sure there'll be some questions while you're in the lab.
Yeah, no problem. Okay, thank you.
Thank you.
And then we try to get as good, perfect AP and lateral films as possible. So why don't you give me a shot of the AP? So that's satisfactory. The spinous processes are in midline. Take a shot. That's the medial border of the facet. Take a shot. Lateral border. Take a shot. Midline. So that's pretty good. So switch to a lateral. Do you have a spinal needle? Take a shot. So 5, 6. Take a shot. Looks all right. I'm a little low. Take a shot. This just gives me an idea using a spinal needle of the trajectory into the facet. So one thing that's a little different with a standard posterior approach is you're not going down perpendicular to the spine, you're going in the trajectory of the facet. So I have a pretty good idea based on that where to make my incision. So then we'll go back to the AP. And lift it up a little bit. Just take a shot of the skin for a second. Okay, and so where the spinal needle went in, I'm going to make an incision. Boy, these scalpels look dull. So you want to not just cut the skin, you want to cut the fascia as well. It just makes it a lot easier passing instruments into the spine. So this tool is called the facet access tool. It's pretty much like a spatula that guides down through the facet. When you're entering any instrument on this procedure, you always want to introduce on the AP. I will usually grab it with a coker, so my hand is not anywhere near the fluoro. Take a shot. Is that reversed? Take a shot, no? Take a shot. Okay, go to a lateral. I advance on the AP down to the lateral mass, and then I'm just holding it on the bone. I think we're at C6-7, so we can start there. Can I have that mallet? Now, let's see, take a shot. Take a shot. So I'm in the joint. I can't rotate it.
So is that like a fixed length? Because some lateral masses are smaller than others. Like say a patient's like 4'8", and their lateral masses. I mean, is that a fixed length, or do you have different sizes?
It's got a stop on it, so you can only go so far. And it usually will run into the pedicle, except C6-7, where it is possible to go too deep, but it has a positive stop on it. So it's a little hard. It's hard to do, but it's not impossible.
Okay.
And so I can tell them in because I can't rotate this. Go to an AP.
You showed on your presentation there's an option to dilate up so you can visually see this. And are you going to do that here, or are you just going to do all like?
Well, I was
percutaneous?
going to do it both ways. We have dilators, so you can do more direct visualization. So I'm a little lateral. It's possible to medialize, take a shot. So I'm going to. Take a shot? No, I'm out.
So, like you talked earlier, like having like two fluoros would make this easier. You could have on the way in got an AP.
Yeah, it's just faster. Take a shot. Take a shot. Take a shot. So that's kind of where you want to be. You want to be on the lateral border of the facet. That looks good. And then we have a rotatory decorticator, which goes over this. Maybe you can back the floor out for a second. This goes down and decorticates the lateral mass. Give me go back to the AP.
Hey, it's Roger Hartle. Just a few comments. I do a number of these. I really like this a lot. And the one thing I learned is navigation is not very helpful here. So I use two fluoroscopy machines because you really need the live guidance. And then with navigation, it's not accurate enough. Especially if you go through all the thick muscle in the neck. Mm-hmm. There's so much movement. I also like it sometimes in open cases. If I go to C3 to T1, for example, I put it in the C3, C4 facet joint just to get really good fusion. And the company used to have allograft spacers. I think they took them off. I don't know, maybe if the allograft is still available. I like that too, but.
We no longer take a AP. Give me a lateral. I would agree with you about, I just don't think the navigation, aside from fluoro, is quite there to do it safely. I mean, a millimeter makes all the difference. In someone who does a fair amount of them, there's not that much fluoro. You can be pretty efficient, but, obviously there's some fluoro. And I just don't think navigation would probably be there in 10 years. It just isn't now.
So, Roger, do you have any other indications than what's FDA approved? Have you used them?
I've used it for C1, C2, and the C1, C2 joint.
Take a shot.
I find that really because sometimes you're right there, and then there's that big gap in the C1, C2 joint, and then I put these spacers in there.
We have several. This is the guide tube, which is inserted in the joint. Once that's kind of the working channel. We have various decorticators to clean out the cartilage.
Are there different heights, or is there just one height spacer or implant you have?
It's one height. The normative data on facets. I mean, there are some people who are smaller and have shorter facets, but it's generally okay. On an occasion, you might want to keep the cage slightly proud if it's a very small person, but right now it's one size fits all. This is a rotatory decorticator. Take a shot. And then the implant, obviously, you fill up the cage with bone graft. The cage is titanium, about 2.5 millimeters, I think 10 millimeters long. It slides in, and then it's malleted in. There's a slightly bigger cage in case it's loose, but in my experience, that's uncommon. Once the cage is in, there's two screws that go through the cage into the superior and inferior facets. So it provides fixation at the level above and below.
So this would be billed as a posterior single level fusion. And also, what instrumentation code is there, or if any?
It's called a facet screw fixation system through the FDA. So it was FDA 510K approved as a type of modification of facet screw, really.
I'm not familiar with the CPT code for that is.
It's posterior nuts.
You know, I'm not a CPT code expert, but, you know, instrumentation at one level, posterior cervical fusion.
Yeah, Paul Holman says it's posterior non-segmental instrumentation. So essentially, a fusion. You know, it's
Yeah.
fusion codes. Okay.
Well, that's what you're doing. And, you know, in essence, it's recreating all the steps. I'm decorticating the lateral mass. I'm actually decorticating in the facet, which most people don't do in a posterior cervical fusion. It's hard to get the angle. Some people will drill a little on the edge of the facet, but this really rasps out the cartilage. And then the screw is fixated into the joint above. It kind of snaps off.
Is there a revision option on this? Let's say it's like you do all this and it's misplaced. Can you get those screws out?
Well, double check twice once you put the screws in, because then at that point you really have to kind of take a diamond drill bit and drill it out. I mean, once you put the screws through the device, it's there. And so, you know, in the clinical trial, we had 200 patients. There was one case in which the cage was too medial. It was removed. So yeah, it can happen. And so, you know, generally I tell doctors to focus on the lateral edge of the facet, and if you're there, you're going to be safe. At this point, I would take bone graft material, usually DBM. That's what was used in the clinical study, and the bone graft material is impacted down.
Are you concerned at all, like, you know, volume-wise? I mean, sometimes you overpack. I mean, could it get into the frame? And would you
Go back to an AP. I'm sorry, the question was?
Well, I mean, if, you know, packing the graft, I mean, I know some people feel more is better. I mean, can you put too much in, you think, or is that space pretty tight?
You know, the only thing I've seen, sometimes if the surgeon's not careful, you can have some graft trailing back into the soft tissues. You know, when you have to make sure it's packed down and then pull everything out together. I haven't seen a case where, like, it's gone into the frame and or caused any nerve problems like that. Take an AP. So that's perfectly positioned. It's on the lateral aspect of the facet. Now, this is a 1-inch incision. I can just go up one level. Do you have a coker? So that was, I think, 6-7. Take a shot. So it's not, I'm basically using the same incision, little medial there. Take a shot. A little too lateral. There's small movements. Take a shot. It's about right. You have a mallet. Go to a lateral. Actually, go back to the AP. I think I might be high. One sec. Take a shot. Okay, and then go to a lateral. So I'm positioned over the facet. A little high. I'm going to raise my hand up a little bit. Take a shot. Take a shot. So that's in. Again, I can feel that. It's stiff. We'll check it onto an AP. I'm going to use these dilators. I mean, some people like an expanded view. I generally don't try to make the tiniest incision because I don't think the skin incision makes the difference. So there, I can medialize a little bit. I'm just going to point medial a bit, take a shot. So I like that position. I'm on the lateral aspect of the facet. Take a shot. And I can shim it over a little bit. Take a shot. Good. And then I have various dilators which I can put in. Yeah. And these dilators just, it's like, I mean, honestly, it's a metrics tube. And this allows you just go to a lateral, better view. You can, through this, it's wide enough. You can take a diamond drill bit if you want to do a little more decortication. It's easy to get in there and do that. So there we are. I'm in the facet, and now I can take out the This is, again, the rotatory decorticator. This is what you're using to decorticate the lateral mass. Flag up. Take a shot. Take a shot. It's on bone. I can feel it. I'm decorticating. Sometimes you can pop out if you're a little lateral. I'm trying to rotate this. I know I'm in. This is the guide tube or the workhorse. It's got a stop on it, so you can't go too deep.
Hey, Bruce, what's the outer diameter of that tubular retractor?
The inner is 15 millimeters. 15 millimeters. I don't know what a metrics tube is.
Metrics can vary. I mean, whatever. It goes from like 12 to 26.
Yeah. Well, it could be made bigger to surgeon's preference. I mean, you could always, it could be made bigger. This again is the workhorse. Let's just check an AP, make sure I haven't moved out of the, haven't moved. I think the trick is you always want to, you got to see the anatomy. You can't see it's not safe. So I like that. I'm lateral. You can see the lateral border. I'm kind of focused a little lateral. I can medialize it a little bit. Take a shot. I like that. Okay, go back to the lateral. And then I'm just going to quickly go through the decortication steps. Can you hit this backwards with a mallet? It's stuck. I mean, this guy's got a tight facet, so we got to put a little. This is a tight facet. It's arthritic. I can feel that. This is, I'm basically decorticating the inside of the facet. It's got a chevron and a serrated face. We have a rotatory decorticator. We recommend you use everything. And then finally, the cage. I'm going to check an AP, take a shot. I came out a little bit. I'm just going to tap it in a little more, and I'm going to raise my hand up. I'm in the, take a shot. So that there's a stop you can see under fluoroscopy, and that should hit the back end of the facet. Take a shot. Good. Give me an AP for kicks and giggles. You just want to check that you haven't moved. It feels good to me. I liked my position on AP and lateral. Perfect. So back to the lateral. And then you insert the cage in. Obviously, you put bone graft in it. I'll raise my hand up a little, take a shot. So you can see on the fluoro image there's a stop, and that should hit the back end of the facet. So At this point, I would put the 2 screws in. I don't think I have to go through that step again. There's a little handle here to disengage from the implant. I'm going to separate it. Now, in this case, I have a tissue dilator there. At this point, my implant is in. Using, loops and a headlight, you can see through this. You can use a little diamond drill bit, and if you want better or more decortication, you can go through the tube and decorticate the lateral mass. And then bone graft can be placed either through this guide tube, or I can take the guide tube out and then just directly impact bone graft through the tubular retractor down onto the spine. Take a shot. So I did 2 levels. I can do 3, but go to an AP. Just take a picture of the wound. Take a shot. So I like that cage position. It's lateral. It's deep enough. And so just back the fluoro out for a second. You can see, just back out for 1 second. So look, in this case, I did 2 levels. It's a 1-inch incision, but basically you can go up to the next level above or below. It's just how much you angle the facet access tool. And, I don't think the skin incision really matters. And the point is that, it can be done really as an outpatient. It's just not a morbid procedure, and you're basically doing all the steps for a posterior cervical fusion.
Well, thanks, Bruce. That was actually a very good presentation. The implants look great. He may look simple. I'm sure there's a learning curve to it. But so if no one has any other questions, thank you. And then we're going to move on to Paul Holman, who's going to talk about ALIF as being the king of MIS surgery. So I'd like to hear that argument.